This video describes a technique for anatomic MQTFL reconstruction. The author reports no relevant financial disclosures. Through a 1-inch incision centered over the supermedial border of the patella, a small incision is made at the junction of the medial border of the quadriceps tendon and the patella through layers 1 and 2. Another incision is made at the distal quadriceps tendon in a partial thickness fashion at the junction between the medial and central thirds of the distal quadriceps tendon attachment. The graft is retrieved through these incisions and folded over onto itself. A looped suture is utilized to place a locking suture, ending at the supermedial corner of the patella. One limb of the suture is then passed through the periosteum at the supermedial corner of the patella to secure the graft to this location. The proximal aspect of the slot in the quadriceps tendon is closed using interrupted sutures to prevent propagation of the defect in the quadriceps tendon. Attention is then directed to the medial femur, and a 1-inch incision is made between the medial epicondyle and adductor tubercle. The bony depression is palpated between the two structures, and a guide pin is placed in this location. The position of the guide pin is confirmed using fluoroscopy to be posterior to Schottle's point. The isometric function of the graft is then assessed to confirm less than 5 mm length change of the graft between 0 and 70 degrees of flexion. Once this is confirmed, the graft is passed between layers 2 and 3 and retrieved at the site of the femoral tunnel. The knee is brought to approximately 60 degrees flexion and the slack is removed from the graft. The graft is marked at the aperture of the tunnel to set the appropriate length of the graft for the reconstruction. In this case, a 20 mm anchor is utilized and a second mark is placed on the graft 20 mm distal to the aperture marking. The femoral tunnel is then reamed and the graft is secured to the fixation device. In this case, an expanding anchor is utilized, which allows the graft function to be assessed prior to final fixation. This includes 2 quadrants of translation of the patella in extension, less than 1/4 quadrant, around 30 degrees of knee flexion, and slackening of the graft in deep flexion. Once these are confirmed, the anchor is deployed within the tunnel for definitive fixation of the graft. The remainder of the graft is amputated and standard closure is then performed.